So how do you choose empiric therapy, especially how do we approach sepsis when multi-resistant organisms are suspected or confirmed?
Yeah, yeah. I think when you
Combination
initiate
therapy, stewardship principles.
yeah, that's of course the challenge, and trying to keep everything within stewardship principles that are essentially aimed at avoiding or reducing antimicrobial resistance development. And we know that the biggest contributor to that are antimicrobial use itself. And this is a vicious circle. If you work in an area where there's a lot of antimicrobial resistance, your empirical therapy will be broad and multiple drugs. And that in itself will also further select even more antimicrobial resistance. So it's important to try to break that cycle. So, how to go about this? I think the first step still is having a tentative diagnosis, because depending on the diagnosis, still your empirical choices may be different. Pulmonary infections, you may treat them differently from abdominal, where you need an antimicrobial cover, from meningitis, from maybe catheter-related infections, where you're more concerned with gram-positives. So you need to understand that having an idea of where the infection is ongoing is an important aspect. The second one is your local ecology, and linked to that is your local antimicrobial guidelines, because your local guidelines should be informed by your local ecology, the biggest problems you have in your unit, and you should target them. You should not target every imaginable pathogen that you may encounter, or if you have encountered in your whole career. It's about the probability that a certain resistant pathogen is involved. And local ecology is a big driver of that. So knowledge of that and having an antibiotic formulary that is linked to that, where specific pathogens or specific infections are treated with specific selected antibiotics is the way to go in terms of choices. And so for me, two important elements is the focus of the infection and the ecology, which essentially together will result or should result in antibiotic guidelines, antibiotic recommendations at your institution level.
So my next question, I mean, you are the best person to ask. We often face the situation. So in hemodynamically unstable septic patient requiring
Mhm.
surgical source control. So of course the patient is on multiple vasopressors, inotropic support, and surgeons understandably reluctant to operate because of high perioperative risk. So what should be the intensivist-led approach? What should be the timing? How do we uh, bridge this and convince
So
surgeons? So what is your take on this?
to obtain source control.
So they would, of
Yeah,
course, say the patient is on multiple vasopressors. If I take him to the OT, high
yeah.
chances of mortality. Then how do we?
It's balancing things out, of course, and again, the first step is having a diagnosis, and source control is important, but it's also important to understand that source control not always means surgery. And source control is as much as about removing an infected catheter, which can be done at the bedside, or draining percutaneously an abscess, which you can do using ultrasound. So there are many different flavors of source control. We do see a trend towards less surgical interventions, with newer technologies becoming available, and interventional radiologists becoming more experienced in draining such infections. But you're right, when a patient is severely ill, when there's severe metabolic disorders, the basic principle is always do not harm a patient. And inflicting more harm is something that, of course, also surgeons are aware of, that there's this risk. You have to minimize the risk, I think, and this basically comes down to choosing the right methodology and understanding that source control not always is like making a big incision and then maybe injure bowel that then lead to new perforations, etc. It is also important to understand that, of course, for some forms of source control, you need others. You need your friends from the surgery department. And rather than involving them late, I always like to involve them early on. When you know that there's a patient coming in with maybe complex abdominal or thoracic or whatever disease that may be treated now with percutaneous drainage initially, I still like to involve them already and say, like, well, this is the patient. Let's look at what the options are. Probably we can drain it percutaneously, but immediately you can already discuss, like, well, if this is not working, we may need to resort to surgery. So involving your surgeon friends early on is important, and involve them in the decision making, and not, call them and say like, we have this patient, you have to operate them. I think nobody likes to be told what to do, and I'm sure surgeons are among that group, and I'm sure it's the same everywhere around the world.
Yeah, I take that from you, and it's a difficult scenario. But as you rightly said, surgeon friends, we have to talk to them, and we have to
Yeah,
involve them in decision making rather than ordering them or
and
telling them what they are supposed to be doing. And
yeah, we have this complex patient. Please come help us.
yes, that's the way.
That works better than, we'll send you this patient and you need to cut out this and that.
Yeah, so got this, and it's a very good message and learning for all the critical care trainees how to approach the surgeons as well.